All right, welcome everyone. Either good afternoon or good morning, depending on where you might be joining us from. Today we're going to be talking about the good, the bad, and the ugly of Medicare drug plans. And the reason that we title this in that way is that if you are on Medicare or you are involved with caring for someone who is on Medicare, this is the time of the year that your mailbox is full of advertisements. The television ads are running rampant, and it's very confusing. So our hope is that when we finish this presentation, the whole way that Medicare drug plans work will be a little less confusing, and that we'll be here to support navigation of that process. I want to give special thanks to Russ Thornton at WealthCare for sponsoring this. And Russ, I'll turn it over to you for a few quick comments.
Yeah, thanks, Cindy. I appreciate that. And, want to welcome everyone that's joining us. And if you happen to be catching this on the replay, I hope you find it helpful. I'm excited to present this information, or have Cindy present this information today. Cindy's with Caribou, which is a third-party organization that I've partnered with recently to offer healthcare consulting to my clients. As we are about to close the window on open enrollment for Medicare, wanted to just provide some educational information that we hope will be helpful for you to either consider or reevaluate your current coverage, or maybe consider changes before the window closes, or for the future. So glad you're here. Cindy, thanks, and I will turn it over to you.
All right, good deal. So today we're going to walk through several topics. We're going to talk a little bit about the history of Medicare drug benefits. Sometimes it's always helpful to understand where you started in terms of how you got to where you are. We're going to talk about the good things that come with Medicare drug plans. We'll talk a little bit about some of the not so good things, or the bad, some differences between pre-Medicare and Medicare drug coverage. And then we'll talk about the ugly, the financial costs that are associated with drug coverage for individuals that are on Medicare. And as Russ mentioned, I'm Cindy Gatton. I'm the Vice President of Healthcare Advisory at Caribou. Caribou is a healthcare planning organization. We support financial advisors with information and data that they can include in your financial plans so that there's an accurate representation of your healthcare costs, which we know to be one of the most significant costs that individuals are concerned about as they approach retirement. This particular tool that we use to present these programs with, unfortunately, it would be my preference if you could just raise your hand and we could engage as though we were all in the same room together. But on this tool, if you look at the lower right-hand part of your screen, there are two little buttons. One is chat and one is questions. We'll be monitoring both of those. And we can try to answer questions during the presentation if something comes up. But generally what we'll do is wait to answer questions towards the end of the presentation. So without further ado, we'll get started. So if you happened to be around in 1964 when Medicare was introduced, at that particular time, people paid for their prescription medications out of their pocket, in part because there weren't many prescription medications. There was penicillin and a few other things, and they weren't very expensive. But between 1964 and 2006, the landscape changed a lot. New medications were developed, including one that a piece of trivia, which I always find interesting. The most prescribed prescription medication of all time, which was Valium, was introduced in the 1990s. There were new medications introduced for the management of high blood pressure, and really an explosion of new drugs that began to come to the market. If you have gone to the drugstore recently, you are probably aware that drug costs have been increasing faster than many other medical costs. And this statistic I find particularly interesting. Of all the money that Medicare spends for taking care of individuals with disabilities and those over 65, prescription drug expenses account for 12% of Medicare spending. That's roughly 10 cents of every dollar. And if you were to go into a retail pharmacy, you would find that roughly Medicare covers about 1/3 of all of the retail prescriptions that are dispensed. So the fact that Congress enacted legislation that said let's provide a way to mitigate the financial costs of these medications is actually a good thing. We have insurance to mitigate a financial loss. And the good part about Medicare drug plans is that they do significantly reduce out-of-pocket drug expenses. Another thing that's good about Medicare drug plans is that, on average, an individual who is trying to make a decision about their Medicare drug plan, if they are on a standalone, Part D plan, or if they are on a Medicare Advantage plan, is that you can change them every year and you have lots of choices. On average, 30 standalone Part D plans and 33 Medicare Advantage plans. That's a lot of choice. Now, if you like choice, you might see that as a good thing. If a lot of choice feels a little overwhelming, well, maybe we'll put that in the not so good category, but still, the fact that there are choices to be made is a good thing. As I mentioned, you can change your drug plans annually or your Medicare Advantage plan annually, so you're not married to it. And there are no requirements to do that other than the fact that it helps to optimize your expenses. These plans are all provided by commercial insurance companies, and that's a good thing. Why do you ask? Well, because these plans are provided commercially, there are consumer ratings for these plans. Now, keep in mind that insurance companies are not the most liked entities out there in the world, so it'd be unusual to see one of these plans rated 5 out of 5 stars. However, you can get a sense of how well an insurer handles customer service, how well they handle prior authorizations by the ratings that are provided for the prescription drug plans and Medicare Advantage plans. And equally important, because these are provided by commercial insurance companies, if something happens that you don't like, coverage is denied, or there's a medication that you want that's not on the drug formulary, you have recourse. These plans are all licensed by state departments of insurance, and there are specified ways in which you can appeal decisions. Now, I mentioned that there was an explosion of new drugs in the 1990s and 2000s, and I wanted to share a little bit about some of these medications that really have changed the landscape of prescription drugs. Many years ago, the condition hepatitis B was uncurable, and it had long-term, very serious healthcare costs because ultimately individuals with hepatitis B have liver failure and are sick for a very, very long time. In the early 2000s, there were medications that could mitigate hepatitis B, could treat it, but the cure rates were very, very low. There are now several drugs available. We named one here, Sovaldi, that basically can cure hepatitis B with 12 weeks of pills, which is pretty amazing because the other treatments were all intravenous. They meant going to a hospital or a doctor's office. And again, the success rate with those medications was not very high, but it comes with a cost. Sovaldi costs about $80,000 for 12 weeks of therapy. And a percentage of individuals do need a second course of treatment. So potentially $160,000. But their hepatitis B is cured, and the long-term ramifications of hepatitis B are mitigated. Some other conditions which are still not curable can be treated with new medications that would be covered under the Part D prescription benefit. Individuals who have multiple sclerosis The condition isn't curable, but there are new treatments that are very effective in improving quality of life and long-term care, but those also come at a cost, about $60,000 a year. Rheumatoid arthritis is another condition which is not curable, but if you watch television at all, you have probably seen ads for Humira. Humira can greatly reduce the joint damage that is caused by rheumatoid arthritis, but it also comes at a cost, about $72,000 a year. And again, these are all medications that are covered under the Medicare prescription Part D benefit. So what could possibly be bad about Medicare drug coverage? Let's talk about a few things. The first and most important thing to understand is that Medicare drug coverage operates differently than pre-Medicare or pre-65 coverage. When you are covered under an individual plan or an employer plan, your medical costs and your drug costs combine to the same annual out-of-pocket cap. Under Medicare, however, there is a cap for medical if you have original Medicare and a Medigap supplemental plan, or if you have a Medicare Advantage plan, there is a cap on your medical expenses, but there is not a cap on drug expenses. We're going to show you some examples of why that's important or how it can impact an individual. But we mentioned those ads for Humira on television, and those ads always end with a little request your copay card from your doctor and your out-of-pocket expense will be limited to $25 a month. Unfortunately, those manufacturer coupons aren't allowed for Medicare beneficiaries. So if you were able to use those coupons in your pre-65 coverage, you will not be able to use them under Medicare. And an important understanding is that these coverage issues, if you will, apply to whether you are on a Medicare Part D standalone plan or whether your drug coverage is bundled under a Medicare Advantage plan. So it applies under both circumstances. If you're on Medicare, or again, if you care for someone who is on Medicare, you have no doubt heard about the donut hole. The donut hole is getting smaller. It has been since the Affordable Care Act was passed in 2010, but it's still there. Not everybody, and in fact, not the majority of people, ever get into the donut hole. But let's talk about these coverage areas under Medicare drug coverage. So the first part of Medicare drug coverage is the deductible. This is the amount that you are responsible for before the insurance company begins to share any of the cost of your medications with you. You're responsible for 100% of the cost of the drugs. That's the first phase. And the average deductible in 2023 will be $505. The second phase is where you and the insurance plan start to share the cost of the medication. And generally, the plan bears most of that expense. So this second phase goes up to a little over $4,000 that you and the insurance company share in the cost of your drugs. And that's where most Medicare beneficiaries fall. However, there are about 4 million Medicare beneficiaries that do fall into the donut hole each year. In the donut hole, your cost share increases dramatically. It's 25% of the cost of the medication, or if it's a generic, the actual cost, until you reach the fourth phase. And the fourth phase is what's referred to as catastrophic coverage. At this level, you would pay no more than 5% of the cost of the medication. But remember that Humira example? Well, if it costs $6,000 or $7,000 or $8,000 a month, 5% of that is still a lot of money, especially when there is no cap on the total cost that you might spend. Now, there's one other bad thing about Medicare drug plans, and that is that the premiums are based on your income. You may have heard referred to a category called the income related monthly adjustment amount. And that comes out to the acronym IRMA, not Irma Bombeck and not another Irma that you might know. Sometimes Irma is disparaged in Medicare conversation, but we share here how the income brackets impact the amount that will be added to your prescription drug coverage. Now, in working with an organization like WealthCare, many financial advisors work diligently with their clients to manage their income so that their taxable income falls into these brackets and their Medicare premiums can be managed to the degree that they can. But this information is important for us to understand. And it's not unusual when people first come into Medicare, if they were still working, that their income may be higher than it will be later in their time on Medicare. But these rates are recalculated every year based on your income from the 2 years previously. So for 2023, the Social Security Administration is looking at the income that you reported in 2021. And that's the basis on which they would calculate whether or not you might be subject to the IRMA surcharge. So we talked about being able to look at how this applies to real people. This is an individual who was aging into Medicare when her birthday was in November. And she had been covered under an employer plan where her medication expenses and her medical expenses were commingled to come to her out-of-pocket maximum, which for her in her plan was $6,000 a year. That's not something to sneeze at, but this was an individual who also had been living with multiple sclerosis for many years. Her condition was well managed, and the medication that she was on, again, sort of commingled with that medical and prescription drug out-of-pocket maximum. And she was using a manufacturer's coupon to mitigate her out-of-pocket expense. When her healthcare planning analysis was completed and we found the plan that was best aligned with what mattered to her, you'll note on this slide that the deductible at that time was $265. The monthly premium was $60.90. This individual was subject to an IRMA surcharge, which at that time was $112.10. And so we summarized what her fixed costs were for the remainder of the year, and we summarized what her drug costs were going to be for November and December of that year. But the big surprise was when we annualized that for the next year, which is that bottom number, $25,000 and change. Now, she had begun her planning in August of the year before she was going to age into Medicare. And when this information was shared with her financial advisor, his comment was, whoa, this impacts our financial planning significantly. But it also allowed the opportunity to have a conversation with her doctor about whether there might be other prescription options for her that might be less expensive. And in fact, that's exactly what happened. Her doctor was willing to alter her therapy, and this number came down substantially, but it is something that we monitor for her on an annual basis. So $25,000 is pretty bad. Could it get any uglier? Well, maybe. Let's take a look. The ugly about Medicare drug plans is that the information is rather in constant motion. Changes can result in unexpected costs. You may remember some many years ago, a lot of news press about a product called EpiPen, a product that individuals who are very allergic need to avoid an anaphylactic reaction. When the price went from $30 or $40 for an EpiPen to over $300, and that happened in the middle of the year. And that's to our second point, is that drug costs can and do change throughout the year. So what you pay in March might not be the same amount that you would pay in October. In Medicare drug plans, actually in all drug plans, there is a tool called the formulary. Now, there are many, many, many medications that are available. The formulary says, for this insurance company, these are the medications that we cover under our plan. They're required to cover medications in all medication categories, but they don't have to cover all drugs. And the formulary can change from year to year. As we mentioned earlier, you can change your Medicare Advantage plan or your drug plan every year, which is why it becomes so important to evaluate the formulary, the drugs that you're on, any of the changes that have occurred over the last year. 7 out of 10 Medicare beneficiaries do not look at their plan every year, if they look at it at all after they first enroll. And 95% of Part D beneficiaries are not on the plan that is cost optimized for their medications. These all contribute to why it's so important to evaluate your drug coverage every year. Let's take a look at another real life situation. This is an individual who has chronic obstructive pulmonary disease, a lung condition, and asthma. And many of the medications in that particular category can be quite expensive because they don't have generic equivalents. When we look at Medicare drug plan pricing, one of the things that we have to be very cautious about is when I'm shopping and I look at the price tag, if the price tag is lower, I would assume that that's a good buy. That isn't always the case for Medicare drug plans. So there are several factors that you have to evaluate. The first one is the monthly premium. This is what we're going to pay no matter what, whether you ever get a prescription filled. So those are fixed costs. So we take the monthly premium and we multiply it by 12. We also then, though, have to look at the pharmacy that you use and the medications that you take. The Part D insurance plans have standard pharmacies and they have preferred pharmacies. Your pharmacy, your preferred pharmacy, may not be preferred by the plan that you're on. Generally, preferred pharmacies have better pricing for drugs than standard pharmacies do, but it's important to look at them. And then the third factor is that we have to look at the actual costs of the drugs. So in this example, you can see that the medications this individual takes are expensive. This is an individual who is going to fall into the donut hole based on their average drug costs. But you also note that the plan with the lowest monthly premium has the highest drug costs. And they are an astounding $40,000 a year versus $5,000 a year with the other two plans that are shown. So this is why it's a bit confusing for many people. If you've got 30 plans available, sourcing through this information to determine which is your best plan requires looking at a lot of data. But I'm a cup half full kind of person, so we'll focus on maybe there's more good than bad. Or as a consumer, what options do you have to be in control over what you spend on your medications? So I've harped on it before, but I'm going to say it again. It's costly not to review your drug coverage or Medicare Advantage plan annually. Think of it this way. If there is even a couple $100s worth of savings, if you're going to be on Medicare for 20 years or maybe 30 years, those small changes can add up to a lot of money over time. There are some common situations that give us ways to optimize costs. First of all, many people's medications will change over the course of a year, and health conditions change. So there may be medications added or deleted over the course of time. I mentioned that standard versus preferred pharmacy. Although nobody likes to have to make a change, making that as an informed decision, yes, I'm going to change because I can optimize some of my savings, but no, the savings that I would get are not worth the change is an important part of being an empowered consumer. And as we mentioned earlier, you have to consider not just the premium of the plan, but also the overall costs. Excuse me, and that includes the deductible and the cost for your medications. I'm somebody that doesn't like change very much. You may be too. And you might be asking the question, well, gosh, this is just one more thing to change. How hard is it to do that? And the answer is, it's a lot easier than you might think. You can call the plan directly once you know which is the optimized plan for you. They can take your application over the phone. Easy, easy. If you have an account set up at Medicare.gov, you can add your prescription medications there. And every year you can do that annual comparison. And then there's a little green button there when you've chosen your plan that says enroll in this plan. You answer about 7 questions and it's all handled for you electronically. It disenrolls you from your past plan and enrolls you in the new one. Or if you have an insurance agent that you work with, if they represent the plan which is most cost effective for you and includes your preferences, then an insurance agent can help you make this change as well. And believe it or not, although we do recommend that at the end of the year, you go to the pharmacy with your new card and make sure they have that information in their system, most of the time it will already be there. So it's not as hard to make a change as it might seem to be. Now, there's one other caveat on this, is that sometimes it can be more cost effective not to use your plan at all. Think cash is king. So we'll talk about a few of what I'm going to call drug cost optimization hacks. And that is, when you're at the pharmacy, always ask what the cash price for your medication would be versus the price that they tell you would be through your insurance. It might be worth it not to use your insurance. There are a couple of other options that people are very familiar with or might be familiar with. One is to use GoodRx. GoodRx will tell you basically what the cash price for your medication would be at a whole list of different pharmacies. So logging on before you go to the pharmacy is a way that you can get some idea of the cash price versus what your cost will be with insurance. There's also a mail order pharmacy in Kentucky called healthwarehouse.com. Healthwarehouse.com does not accept any insurance. So basically what you get there is you've avoided the middleman and your price is what the drug wholesaler's price is with a bit of a markup. If you like that idea, if you use mail order and you're comfortable with it, your physician will find healthwarehouse.com when they're ready to e-prescribe for you. It is a licensed pharmacy. It's available in all 50 states. So that's an option as well. If you go to the pharmacy and your prescription is a lot more expensive than it was before, ask the pharmacist if the formulary for your plan might have changed mid-year. Sometimes that happens when a new generic is released. Sometimes it happens just because it happens and the insurance company's gotten a better price on a different drug. This is the time to have a conversation with your doctor about whether this is still the best medication for you or whether it might be possible to switch you to something that would have less of a cost implication. As we mentioned before, changing pharmacies can lower costs, but there's a cost in doing that in terms of changing prescriptions, but it's something to evaluate if you're very price sensitive around this. And lastly, nobody loves tracking their medication expenses. Some pharmacies will do it for you and track all of your out-of-pocket expenses. But in our health planning analysis at Caribou, we do provide information about medical tax deductions, and your out-of-pocket expenses for medications are a tax-deductible expense. So it can be worth keeping track of them just to make sure that you're not missing out on a way that you can optimize your financial situation. So what we do at Caribou is called a health planning analysis. We collect information about your preferences for how you want to access healthcare, specific information about your health, your budget, and more information that you and Russ are able to use as you complete your financial analysis and financial planning for the year. If doing a health planning analysis would be important to you, Medicare open enrollment does end December the 7th, and it does take about 3 business days for Caribou to compile that information into an analysis. Any changes that you want to make for Medicare this year do have to be input by December 7th at midnight for them to be effective January 1. And Russ can tell you more about how you would request that if that's of interest to you. So we've reached that point where I can monitor the chat and the questions to see if you have any specific questions about this. Our hope, as we mentioned, is that we've taken this very confusing topic and perhaps made it a little bit easier to understand. But we are also available to answer questions as a result of your doing a health planning analysis and questions now. So I'll take a look at the chat. And Russ, do you have any questions that we could incorporate?
Yeah. So first of all, Cindy, thank you. This was great. I always learn something when I talk to you or listen to you. So so I got something out of this. Hopefully the viewers did as well. While you're checking the chat to see if any questions come through, I do have a couple of questions that I do know come up pretty frequently when it comes to Medicare drug plans. And I thought maybe I'll just bounce a couple off of you. The first is, what's involved with changing a drug plan under Medicare if someone moves? So if they move from one part of Georgia to another or one part of the country to the other, does that necessitate a drug plan change? And if so, is there a time limit or a window during which they have to make that change?
That is a very astute question. So well, let me back up by saying, if you are on original Medicare and you have a Medigap plan, your Medigap plan goes with you no matter where you live. However, if you have a standalone prescription drug plan or a Medicare Advantage plan, those plans are licensed by the county that you live in. So if you move within the county, you don't have to make any changes. But if you move out of the county, you would go to the Social Security website, ssa.gov, and when you change your address there, you have 60 days in which you can enroll in a new standalone Part D plan or a new Medicare Advantage plan. So it's triggered by when Social Security finds out that you've moved. And it's always often better if you can be proactive about that. When you know your timing for your move, you can set yourself up. You can actually access ssa.gov from your phone if you care to. But know then that the clock starts ticking and you've got 60 days to get enrolled in a new plan. So ideally, you would want to do your health planning analysis before that so you know which plan it is that you will want to change to for your new location.
Got it. That's super helpful. Thanks. Another question I'd love your input on. So you've already spoken a little bit about how Medicare participants can reduce drug costs. But what if their primary physician or their caregiver really insists that they stick with a brand name prescription instead of a generic that perhaps would be a little less expensive?
So that's a clinical decision. And hopefully we have relationships with doctors that we trust that they can explain to us their rationale for wanting us to be on a medication that might be expensive. Some medications, some of the manufacturers for brand name medications, if there is no generic available, have grant programs for which they can provide medications to Medicare beneficiaries and kind of skirt that coupon issue and be able to provide it if one's adjusted gross income meets certain levels. And for some drugs, and I'm especially thinking of certain oral cancer medications that can be extremely costly, the income limits are quite high. It's not as though one needs to be at the federal poverty level to qualify for those plans. But in the situation where there's not a grant available, there are other resources that will provide medications to seniors that have expensive medicines that they don't feel will fit into their budget. Alternatively, though, these are tax-deductible expenses. So it becomes very important to track the cost of those if your doctor really feels that a brand name medication is important for you. And lastly, if your doctor's prescribed a brand name medication that is not covered under the plan that you're on, you can have the doctor request what's called a prior authorization so that the plan does cover the drug and that it does accrue to your expenses, to that donut hole, to try to get out the other side to where your costs are minimized. That's a tough situation, Russ, for sure.
Yeah. I've got one more question, Cindy, but before I do, I don't see any questions that have come through. Do you see any on your side?
I do not. I do not.
All right. So one question, we can wrap things up. You mentioned at the top of the presentation that there are no caps on drug costs through Medicare, but that's set to change. So there's legislation that in 2025 that's going to introduce some cost caps to prescription coverage through Medicare. My question is, will those caps apply to everyone across the board? Is it going to be, depending on whether you're on Advantage or a Medigap plan or a standalone plan, or is it a little bit more involved than that?
Russ, thank you so much for bringing that up. Because it's in the future, we didn't include it in the formal part of the presentation, but you're referring to the Inflation Reduction Act, which includes several things that are of real benefit to Medicare beneficiaries. One is that any individual who takes insulin will find that beginning next year in 2023, their insulin expenses will be capped at $35 a month. There are a lot of brand name insulins out there that have cost people hundreds of dollars a month. This is going to be a real boon to any insulin dependent diabetic. And as you mentioned, there are different steps in this where there will be increasing benefits. But in 2025, there will be a cap applied to out-of-pocket drug expenses for Medicare beneficiaries. And that will be true whether you're on a Part D plan or a Medicare Advantage plan. And that cap will be $2,000. So again, doesn't apply to that many people, 5.5 million people right now, maybe more, because we think about the coverage gap at $4,000 some dollars. But that will be a way in which we can predict an absolute worst case scenario for individuals, no more than $2,000 in out-of-pocket drug expenses a year.
Got it.
Great question.
Yeah, well, thank you for that. And I know that there's a lot that can and probably will happen between now and then, but it's good to kind of keep an eye down the road and see what we might be able to expect under Medicare going forward. Cindy, this has been great. I know this has been super helpful and valuable for my clients and other people that might be checking this out. Before we wrap up, any closing thoughts? Anything else you would add?
No, but I was going to say 1 second. I did see a chat come in. Cheryl, thank you so much for joining us. I see another comment coming in. Jean is typing at the moment. Jean also sends her thanks. And we at Caribou are really appreciative for our partnership with WealthCare. So thanks very much, Russ.
Yeah, well, likewise. Cheryl, Jean, thanks for joining us. If you or anyone else watching this has any questions about drug coverage or would be interested in exploring a health plan analysis through my partnership with Caribou, reach out and let me know. With that, Cindy, thank you again, and I wish everyone a happy holiday and look forward to talking to everyone again soon.
Take good care.